Hey, I'm Kreton Mavromatis here at the ACC Scientific Sessions, here with James Hermiller. We're both editors of the upcoming SCAI-TAVR Center, and we've been attending some of the sessions on TAVR here, and would like to tell you a little bit about what we think. What do you think, Herms, about the presentations in the last couple days about TAVR?
Yeah, this has been a particularly good ACC for TAVR. Some exciting news, I think. For me, the core valve high risk or higher risk randomized trial was sort of one of the high points for sure.
Absolutely.
You know, in that study, 750 almost patients randomized either to surgery or core valve. And the bottom line was the 1-year mortality was significantly lower in the TAVR group, 14%, and it was 19% in the surgical AVR group.
First time that's ever been shown for TAVR to be actually superior in these hard outcome of mortality over surgical AVR. So that's a big deal for our profession.
Yeah. I think the other aspect of the trial that is noteworthy is the stroke risk, major stroke risk. Stroke was no different between surgical AVR and TAVR, which is also, I think, a noteworthy finding compared to some of the other data that we've seen before compared to surgery. And that really held out to 1 year where, at least numerically, the stroke rate was higher actually in the surgical group compared to the TAVR group.
Yeah, that's very impressive and a different finding than PARTNER from years ago. Well, that brings us to the question of what valve do we use for which patient?
Yeah.
It's the one that burns in everybody's mind, I think, when they hear about this this relatively new technology core valve being approved and now hopefully being approved for the high-risk patient. What do you think?
Yeah, I was just going to say, what do you think? And it's a tough question right now. Any insights from?
It's tough, and everybody said it. The cross-trial comparisons are difficult to make with the level of certainty we'd like. Core valve showed us superiority to surgical aortic valve replacement. PARTNER some years ago didn't. But obviously different studies, different analyses, different patient populations. The CHOICE study was revealed today, probably the first randomized controlled study looking at the balloon expandable versus the self-expanding valve. 240 patients, study done in multiple centers in Germany. Patients all high risk for aortic valve replacement and randomized to the core valve versus the SAPIEN XT. And the primary endpoint in this short study with a smallish patient population was device success, which the German investigators found to be better in the balloon expandable valve patients, which was interesting. 30-day outcomes, their secondary outcomes, I think showed no difference in mortality, some increased paravalvular regurgitation, and increased CHF hospitalization in the self-expanding stent group. That was kind of interesting. What did you think about that?
Yeah, I think it was interesting to have at least some small randomized data set. Kind of my questions are: one, was it really systematic CT analysis to decide what size of prosthesis? I think if you look at the aortic regurgitation numbers, just in the randomized trial that was presented compared to surgery, the AR rate is much lower. They sort of decided aortic regurgitation severity based on angiography, which we all know is a little in the eye of the beholder, and there was no core lab echo. I think the other thing probably with self-expanding is that AR over time gets a bit better as it remodels, and probably the 30-day endpoint's not quite the right one, but still very interesting data.
Very interesting, and it's going to be definitely food for us to think about for the next 6 months, 2 years, until we get either bigger randomized controlled trials or big registries to give us a little bit more insight into that. What else? I wanted to mention that I thought there was also a lot of interesting subgroup analyses from the PARTNER studies showing that the TAVR seems to work for some of the subgroups that lay on the fringes of the aortic stenosis population, namely the bicuspid aortic valve replacement patients, the surgical bioprosthetic valve degeneration patients. Those valve-in-valve technique seems to be effective. There was some data supporting the transaortic approach in patients without femoral access, still an important subgroup, even though the delivery system sizes are decreasing and femoral access is becoming a better and better option for our patients. How about you? Any other thoughts?
I think the other theme that I take away is the declining complication rate. Which is probably a function of smaller devices, but better experience and maybe a reduction in the risk of the overall population that we're treating today. But it's a trend both in terms of major bleeding, vascular injury, stroke. You kind of look at all of these complication rates; they seem to be declining.
Yeah, I agree, and I've been impressed, at least at the few presentations here, talking about a more stent-like procedure approach to placing the transcatheter valves, where the procedures are done in the cath labs without as much hoopla, without general endotracheal intubation, without TEE. I've been interested in that whole movement towards the cath lab and the minimalist approach to TAVR.
Yeah. So I think overall, really an exciting ACC for the field.